Hello, my name is Dominick ANGIOLILLO, and today I'll be speaking to you about ADAPT de-escalation, and I've also introduced the concept of escalation options after bifurcation lesion with two-stent techniques. These are my disclosures. So when we speak about the de-escalation, we're speaking about switching from prasugrel or ticagrelor to clopidogrel as a strategy to reduce the long-term risk of bleeding without any trade-off in ischemic events, while escalation is the switching from clopidogrel to prasugrel or ticagrelor as a strategy to reduce thrombotic complications without a trade-off in bleeding. And what we do know is that this strategy works, and more specifically, when we're speaking about a guided escalation or guided de-escalation approach. And when we speak about guiding, this is by the use of either platelet function or genetic testing. As you can see, as mentioned before, the concept of escalation, you reduce ischemic events and thrombotic complications without a trade-off in bleeding. And while the de-escalation, it's a reduction in bleeding without a trade-off in thrombotic complications. Now, it is important to keep in mind that when we're speaking about bifurcation with two-stent techniques, this is by definition a setting of high thrombotic risk as recognized by the ESC guidelines. So when we're speaking about de-escalation, this by definition implies that a patient is already on a potent P2Y12 inhibitor, such as in the setting of an acute coronary syndrome. And therefore, the recommendation in general is not to de-escalate unless you have a good reason. And this could be due to drug access or due to non-bleeding side effects, for example, dyspnea if the patient's on ticagrelor. But for the most part, we also can consider prasugrel in some of these patients if there isn't a contraindication. So truly the reason to de-escalate in these patients, if you really have an individual who's also at high risk for bleeding complication, an HBR patient. And the reason why we are concerned is very simple. We know that if you de-escalate, you're going to a drug which is clopidogrel, characterized by a broad degree of inter-individual variability. And therefore, you have a significant number of individuals who remain at risk for thrombotic complications. So the general rule is do not escalate soon after PCI, and beware of the fact that you have an increase of platelet reactivity due to a number of reasons. One, you're switching to a less potent P2Y12 inhibitor with clopidogrel. You have the pro-thrombotic environment post-PCI, particularly for the setting of an acute coronary syndrome. And let's not forget that when you switch, particularly if you're going from ticagrelor to clopidogrel, there is a risk of drug-drug interactions. And we have plenty of data to support this. This is one of the many registries, such as the SCOPE registry, showing that when you switch early, particularly in the early post-PCI phase, and this is, again, it's not specific to bifurcation, this is specifically the patient with acute coronary syndrome, there is an increase in thrombotic complications. So definitely we would not want to put ourselves in this position, particularly if we have a patient with recently treated with two stents for bifurcation in the setting of acute coronary syndrome. The second rule that we should consider is that consider waiting at least 30 days before de-escalating. And ideally, de-escalation should occur when guided by platelet function or genetic testing, as I already mentioned before. Now, each one of these tests have pros and cons. One of the things to keep in mind that if you're considering de-escalating to clopidogrel and you want to understand the response, platelet function testing may not be the best option because the patient actually needs to be on the drug to define response. And so sometimes it may be a little bit too late to understand whether it's worthwhile to be on clopidogrel or not if you're just relying on platelet function testing. And this is the advantage of genetic testing because genes don't change. And the only issue is that genetic testing is not always a direct measure of response. But we can improve the accuracy by the way which we use genetic testing and predict response by using a score. This is the ABCD gene score, which integrates genetic information together with clinical information A, B, C, and D. In other words, age, body mass index, chronic kidney disease, and diabetes, each one with an integer scoring system. And if the score is above 10, you have a very high likelihood of being a poor responder to clopidogrel. This is something that we do use in our practice now that we have rapid genetic testing assays that give you a result within 1 hour. Now, an alternative of de-escalation, although it's really not the true concept of de-escalation, I'm going from a more potent to a less potent P212 inhibitor, but yes, considering reduction in antithrombotic agents, is that of stopping aspirin. And you can see here, there's an analysis from the Twilight Complex, the Twilight study, which is the Twilight Complex analysis, which did include as one of the anatomical factors bifurcation with 2 stent techniques. And what we learned from this analysis published by George Dangas in JACC is that there is consistency with the overall trial findings. So significant reduction in bleeding without any trade-off in ischemic events. When it comes to escalation, this implies that a patient is on clopidogrel, such as a patient with stable CAD, and it's a reasonable approach if a patient is not at high bleeding risk, if you're concerned about poor clopidogrel response. In my practice, I consider prasugrel over ticagrelor if there are no contraindications, simply because prasugrel is a true PCI drug. It's a once daily regimen. There is no dyspnea, and there are no concerns about drug interactions when switching back to clopidogrel if needed at a certain point. So again, it's not because there is any specific pharmacodynamic difference. I just think it is a more user-friendly approach to consider prasugrel if there aren't any contraindications. And last but not least, when switching, whether this is a de-escalation or an escalation, always switch to the alternative agent using a loading dose administration, and you probably want to do that 12 to 24 hours after the last maintenance dose of the drug. If you're doing a de-escalation strategy instead of you're doing an escalation strategy, it really doesn't matter. You can do it even right away because there aren't any interactions when you escalate to a more potent P212 inhibitor. Thank you very much for your attention.